For those of you who cannot tell, I am not Julia Lear, the board chairperson. Julia sends her regrets and apologies. I'm Steve Rosenberg. I'm the president of COCHS, and on behalf of Julia and our whole team, I want to welcome and thank you for joining us today for this very important conversation. Approximately 2 years ago, in this very room, we convened a meeting to focus on the implications of health reform for jail-involved populations. We then saw very clearly the opportunities created under the Affordable Care Act to improve both public health and public safety. We had a great discussion. It's on our website for those of you who want to read about it or watch it, about the many ways we could move forward to leverage those opportunities. Today, we're here to discuss another set of opportunities for reducing health disparities. We all know that health disparities are a persistent and significant problem in this country, despite the hard work of various groups, including the National Minority Quality Forum, which is our co-host today. With the anticipated growth in minority populations in the coming decades, this issue is likely to take on even a higher profile. By extending health care to an estimated 32 million Americans, many of whom may be racial and ethnic minorities, health reform will likely help reduce, if not eliminate, some of those health disparities. We all know that a great deal of work is underway between now and January 1st, 2014, when Medicaid expansion will be implemented in the states, and the states will have their new health insurance exchanges up, be they the state exchange, the federal exchange, or the hybrid exchange. Yet, if we want to assure that health reform fully addresses racial and ethnic disparities, and I think that's all of our goals within this room, jails need to be part of that plan and part of that conversation. Unless we can figure out how to meet the health care needs of the millions of American, 10 million unduplicated, who interface annually with our nation's jails, we cannot make a significant difference in health disparities. And why is that? Do I need to tell anyone in this room that those involved with the criminal justice system are largely non-white, largely male, largely uninsured? They will make up a significant portion of the newly eligible population under health reform. They tend to have serious health problems, high rates of chronic disease, and of course, very, very high rates of behavioral health disorders. Through health reform, many of these folks will have access to health, mental health, and substance abuse treatment for the very first time. I like to joke that when I go through jails, which I'm blessed enough to do frequently, often the last time a lot of these young people saw a doc was their junior high school sports physical. In this very way, we have an opportunity to address the problems that are often at the root of criminal behaviors. Expanded community-based treatment for jail-involved individuals will not only improve their health and reduce disparities, but as Dr. David Mancuso's data shows, it has the opportunity to reduce crime, to reduce recidivism, and to bend the cost curve in healthcare. Jails, then, are the nexus, the point at which we connect a population that has a high need for specific services with the services that we need. That's when we at COCHS talk about connectivity. That's what we mean, the building of bridges between jails and their communities so that jail-involved individuals can get the treatment that they need and that they want to, regardless of whether they're in the jail and in the community. How we take advantages of these opportunities under healthcare reform, that's what we want to talk about today, and we want to talk about it today specifically from the lens of disparities. We have a very exciting agenda. Gary Puckrein, the President and Chief Executive Officer of the National Minority Quality Forum, will start us off, providing us some background data so we all understand the nature of the problem. Then we're extraordinarily fortunate to have Tanya Robinson, the Special Assistant to the President for Justice and Regulatory Policy of the White House Domestic Policy Council, will be giving us the keynote. We will then hear from 4 panels of experts who will discuss various issues and options learned from the early adopter states. We've allotted time for audience participation. For those of you who've been to these meetings before, you know that we'll have some of our research associates in the audience with microphones so folks can make sure they have plenty of opportunity to ask questions or comments, and if you'll raise your hand, one of my trustee staff will bring a mic to you. A few housekeeping details. Restrooms are at the bottom of the stairs and to the right. If you haven't already, can you please silence your cell phones while the meeting is in session? Lunch, as usual, will be on the second floor of the Thunder Grill Cafe. You go downstairs, make a left, and it's the opposite corner of Union Station. You will need your meeting badge to be admitted, so please wear your badges. Recognizing that everyone is a busy people with places to go and planes to catch, we will do our best to be extraordinarily punctual. Those of you who know me know I have a habit of being extraordinarily punctual. We would like to ask you at the end of the meeting if you can take a very few moments to fill out your evaluation form that is in the back of your packets. Once again, I want to thank you for joining us and participating in this conversation. And I'd like to ask Nancy Barrand, the Special Advisor for Program Development at the Robert Wood Johnson Foundation, to now come up and say a few words. And I want to again thank Nancy and the Foundation for all of their support.
Well, thank you, Steve. Steve is very punctual. He started us actually at 8:28. So we've saved 2 minutes already. Good morning. On behalf of the Robert Wood Johnson Foundation, welcome and thank you for joining us today. The mission of the Foundation is to improve the health and health care of all Americans. We place special emphasis on looking for ways to reduce the health disparities we see in our communities. We know that the health disparities we see in the community are mirrored in the jails, and if you take away one message from today, it's that we cannot hope to address one problem without addressing the other. The Foundation created COCHS and has continued to sponsor its work in order to connect the jails to the rest of the healthcare system, in order to improve health outcomes, but also, we believe, to help reduce recidivism. As you will hear throughout today, we are at what we think is an opportune moment to create change and to connect the jails to the healthcare system, given the changes that we're seeing in health information technology, the advent of electronic health records, health information exchanges, the new payment incentives that are coming into place under the ACA to promote greater prevention on the part of providers, and the real game changer, the expansion of Medicaid in 2014. We need to be ready to take advantage of these opportunities to create an effective system of care that recognizes that jails play an important role both in the health system as well as in our safety net. The Foundation is honored to be co-hosting this event with the National Minority Quality Forum, and I'm pleased to be able to ask Gary Puckrein, the founder and CEO of the forum, to come up and lead us off in this event. Thank you.
Hello and welcome to Health Reform and Criminal Justice, addressing health disparities among the racial and ethnic minority populations in jail. To set the stage for today's event, Dr. Puckrein, who is the president of the National Minority Quality Forum and chief executive officer of the National Minority he's the CEO of National Minority Quality Forum. He'll provide an overview of the racial and ethnic disparities in health and criminal justice status that exists nationally. In addition to his work at NMQF, Dr. Puckrein also serves as the Executive Director of the Alliance of Minority Medical Associations, which is a collaborative effort of the Asian and Pacific Physicians Association, the Association of American Indian Physicians, and the National Medical Association. In '98, Dr. Puckrein founded the forum's predecessor program, the National Minority Health Month Foundation, to help communities and policymakers eliminate the disproportionate burden of premature death and preventable illness in special populations through the use of evidence-based, data-driven initiatives. Dr. Puckrein was awarded his doctorate from Brown University, graduating Phi Beta Kappa. Without further ado, Dr. Puckrein.
Good morning. I thought what I would do this morning is to, rather than just go through a litany of health disparities, I go to a lot of health disparities conferences, and at the beginning someone stands up and goes through the litany yet one more time. And I'm going to talk about health disparities, but I want to try to get to some fundamentals. What I want to suggest to you today is that health disparities are actually structured, that there is a real underpinning to them. So I can get the slides up? Oh, do I need to do it? Okay. Down. Oh. It's not moving. That's why I'm first. We're going to get technology working here. Am I pressing the right one? Yeah, okay, there you go. I'm going to introduce the National Minority Quality Forum, and then I'm going to talk a little bit about the existing marketplace and then healthcare reform in terms of health disparities. But let's start at the beginning. I always like this slide. This is the money slide. This tells you how we fund healthcare in the United States, because we have a really very interesting model. The first thing that we ought to appreciate, because Americans tend to always lose sight of this, is that all money in the healthcare system comes from the American public. Every nickel, every penny, every dollar in the American healthcare system comes from the American consumer. Now, we've got a couple of models. During World War II, private insurers came into the marketplace. Government was sort of holding down wages and the way in which employers began to induce workers to come to work for them. They started to give them health insurance. And out of that system, we got that private sector, that private health insurance. So everyone who had a certain kind of job got health insurance. And by 1965, somewhere around a third of the American population was getting health insurance from their employment. That's a very important thing to say, because what we're also saying is that 2/3 of the American population was not getting health insurance. And why is that important? Health insurance is the way in which we purchase health care in the American marketplace. It is not possible for the individual consumer to go into the marketplace, anticipate their need, and buy the health insurance, the medical care that they need. So the same way that you have to have homeowners insurance and car insurance, you want to spread that risk around so that at the moment of need you have access to the care that you want, you use health insurance. That's what's happening in the marketplace. So what I'm also saying to you is that anyone who does not have health insurance, cannot go into the marketplace, generally speaking, on their own and purchase continuous medical care. So the problem occurred that in 1965, the government looked at it and said that seniors, people who were retired, were not able to acquire health care because the private sector could not come up with a premium. They couldn't price a product that the seniors could buy in order to cover themselves. Hence, we got Medicare. Government came in through taxes, at that other line up there, that federal line, that's where that came from in 1965, and provided care to seniors because the marketplace could not come up with a model for them. At the same time, government said, we have the indigent population, those who were poor, and we will provide medical care to them, to a portion of them, through Medicaid. So 1965, we got Medicare and Medicaid. So now we have two insurance models. We have the social insurance model of government, and we have the private sector model. Medicaid also, what the feds did at the time was have the state contribute to it. So you have the state involved in the distribution of health care through Medicaid. Medicaid reminds me of, and we can talk a lot about it, reminds me of sort of 19th century almshouses in which you actually don't care what they get. You just want to soothe your mind and say we gave them something. And that's how Medicaid seems to work. If you go down and you actually look at the quality of care, particularly for people who have chronic diseases, Medicaid is a little bit better than nothing, but it ain't real health care. So what we ended up having now, between Medicare and Medicaid, we ended up where by 2008 we had around 51, 55 million people, depending on how the employment market worked, because if you lost your job, you lost health care. So you had somewhere around 51, 55% of the population without insurance. And what I'm saying to you is, if you don't have insurance, you can't really go into the marketplace. So, quick example, if you go to a pharmacy, if you go to your doctor's office, if you go to a hospital, the minute you open the door, they say, can I see your insurance card? Because that card says what you're eligible to get, how much you're able to get, when you're able to get it, and who can give it to you. So if you don't have that card, you're really outside the health information system in this country. The other side of the ledger, that provider side over there, everybody who works in healthcare gets paid through those banks. So you should think of those private insurers in governments, they're really banks, right? That's where you took your money, if you were in the private sector as an employer, and got your insurance that way. Those are your wages that you put into that bank. If you were taxed, those are your dollars. And they tend to pretend like that's really their money. You get really confused about who has what money, where it came from, how it gets dispersed. That's a whole nother conversation. But it's important to know that those providers over there, they get paid from those banks. And a lot of good things have happened out of that system. A lot of the innovations and new technologies that we are benefiting from in terms of the extension of our lives and quality of our lives are really a function of being able to aggregate all of that risk and create a market, a consumer market for healthcare. But what I'm also saying to you is we have lots and lots of Americans who are not really consumers of healthcare because they don't have a card. All right, so now I'm going to talk a little bit about us, then I'm going to tell you the implications of that structure that we have in healthcare for minority populations specifically and the jail population in particular. So we got started in 1998, and actually it was a grant from the Robert Wood Johnson Foundation. We got a little small grant back in 1998 that allowed us to begin collecting data at the zip code level. And the reason why we started this is David Satcher was in the middle of launching Healthy People 2010. And I spent a number of years at the Smithsonian publishing a magazine. And one of the goals of Healthy People 2010 was the elimination of health disparities. And from my publishing experience, I knew there are about 38,000 zip codes in the country where people live. 70% of all African Americans live in 2,500 zip codes. So everything we're going to talk about today in terms of health disparities and jail populations is 2,500 zip codes for African Americans. 50% of Hispanics are in 1,500 zip codes. So we're talking 5,000 zip codes where we're seeing the movement of prison populations and excess diabetes and all of that stuff is 5,000 zip codes. So what we wanted to do was to collect the data on the 5,000 zip codes. But we said, well, we need to compare. So rather than just collect data on the 5,000 zip codes, we collected data on the whole country. And so we built a database of about 800 million records down to the zip code level, disease prevalence, cost, outcomes, you name it. And we use that data to look at advocacy and education and public relations. We've got about 70,000 people who use our data, lots of patient organizations, American Diabetes Association, and others use our data to look down at the community level to see what's happening. Lots and lots of partners, just about every major pharmaceutical company, medical association, et cetera, are using our data. And what we tend to do is, if you go out to the internet and you go to our website, we have these maps down to the zip code level where you can look at disease prevalence and cost and comorbidity and drug use. And then we aggregate it up by congressional district and state legislative district, because healthcare policy, how we collectively decide to make health information, and that's what I think about in medicine and devices and going to the doctor, is really health information. How we decide to make health information available and who we make it available to is really regulated through our elected officials, right? And so we want them to know how their constituents are faring, and then we can do a lot of predictive modeling, and I'm going to talk to you about that in a second. So these are some of our indexes. The diabetes index is 30 million graphs, tables, charts about diabetes in America, and we've mapped HIV/AIDS and hepatitis C and things that really impact minority populations. So this is just an example. This is a map of the United States showing the prevalence of diabetes down to the zip code level. And in those red areas, at least 14% of the population is diabetic. We know the physicians who are practicing in those communities. We know what they're prescribing. We know a lot about what's going on. So what have we learned from looking at all this information? First of all, there are geographically bound healthcare marketplaces in the United States. So I think of healthcare as a sort of marketplace. I'm going to take you back to that consumer model, because I think it's important to understand what's happening to minority populations and to the incarcerated population. So when you get sick, you have to really go shopping in order to manage whatever the illness is, be it diabetes or kidney disease or a mental health disorder. You have to go to the marketplace in order to find something to correct the problem. And when you look down at the zip code level, what you find is that these diseases tend to congregate in certain communities, have a higher level of expression in those communities. And so it gives the market a shape and stability, right? What you also see is that the way in which people consume healthcare is pretty stable. The example would be people with diabetes have a high risk for cardiovascular event. Those cardiovascular events are absolutely predictable at the zip code level. You can look at the zip code and say, next year in that zip code, we're going to have X number of cardiovascular events from people with diabetes, and it doesn't change very much from year to year, about 1 or 2%. So what's driving that stability? The stability is the way in which people consume healthcare. The objective reality, people getting sick, it tends to be fairly stable from year to year. The underlying consistency in the way in which people respond to the disease. So if you have a mental health disease or diabetes or kidney disease, and you don't have that card, the way in which you're going to respond to that disease may be very, very different from someone who has health insurance. Some of it is also cultural, in the way in which people culturally respond to the disease. There's also practice variation. So when you look at the minority community, a minority physician has about 5,000 people, I'm talking about primary care, has about 5,000 people within his patient base. Annually, he's taking care of about 5,000 patients. In the white community, it's about 3,000. And part of the reason for that, is you'll see shortly, is that in the minority community, they are taking care of a lot of Medicaid patients. Medicaid reimburses very, very poorly, so they have to stack more and more patients on in order to get the kinds of compensation that they're looking for. And at the end of the day, the way in which they practice medicine gets influenced by that. They have less time with the patients, they have less money to buy office equipment, et cetera. So you'll see a lot of practice variation based on sort of the market that physician is serving. And then there's also uniformity in the way in which the healthcare financing system works. I'm ever amazed in the 21st century that we have elected officials who say certain people should not have health care. Now, they don't say it as directly as I'm saying it to you, but we have governors of states who stand up and say, people in my community should not have access to health information. That is a stunning thing for an elected official to say, but they say that. And the system gets built that way. And the system gets built that way. And we also decide to tear healthcare system. There is no reason why a healthcare system has to be built around money, influence, but it gets informed that way. So when you take all that together, we see tremendous stability in the marketplace. And you can really anticipate how people are going to consume healthcare based on prior patterns. And we think that's the value proposition. By understanding how people are accessing, getting sick, we can begin to manage our healthcare resources. So now let's take a look at the minority population, because these are important numbers. These are numbers really pre-healthcare reform. So if you look at that African American community, for example, right, and you look at Medicaid and uninsurance, right, 50% of minorities, right, don't have commercial insurance. They have Medicaid and they're uninsured. That's like being in a country where everybody has the credit card to go shopping and you can't. And if you look at the Hispanic community, right, 57%. And you know what that translates to? It translates into this. This is the number that you need to pay attention to. Almost 80% of every healthcare dollar in the United States is spent on whites. That is the number. 80%. Even though the population is changing, demographic shifts are occurring. So in 2000, the white population was about 67% of the U.S. population, and they were consuming 80% of every dollar in healthcare. They're now 62%, and they're still consuming 80% of every dollar in healthcare. We did a great exercise for one company. They were looking at hip replacements, which is there's a big disparities in terms of minority populations and hip replacements. So we took a look at California because California had flipped, meaning it was a majority population. 80% of every hip replacement in California in 1990 was done in whites, and today 80% of every hip replacement in California is done on whites, even though the market has shifted. So, healthcare reform. So what we're doing here is we are now providing this population with a credit card in order to allow them to come into the marketplace for the first time. There are a whole lot of folks who scream and holler about that government should not be allowing those people to go shopping, that there's really something fundamentally bad and evil about allowing these people into the marketplace to acquire health care. But in effect, that's what health reform has done. And so what we're about to see is we've got 35 million people who are basically coming into the healthcare marketplace. 17 million of them are coming through the exchanges. Now, the exchanges are really important. We got to fight about the exchanges because if you remember the model that we looked at earlier, historically, the aggregator for the insurance company in terms of their beneficiaries was the employer. And so they saw the employer as their customer. Now, the insurer has to go to the individual consumer and persuade them to be a member. That is so very important for the minority community. That's extraordinarily important because now they're going to come to the minority community and talk to them about health care. That's important. They've never done that. And now, in order to get at that population, they're going to do that. Be honest with you, when I look at expanded Medicaid and Medicaid, we have some real reform work to do there. There's an attitude and a feeling about what we give those populations that really do not push quality health care. So we've got to pay a lot of attention to what happens with Medicaid. So the minority populations, remember those 5,000 zip codes? Well, that's where health reform for the minority community is about to take place. 43% of all of those people coming into the system now are going to be minority. And it's all going to happen in about 4,500 zip codes. And guess what? There are 500 minority-serving hospitals in the country where they are going to come to. Yes, there are minority-serving hospitals in the country that predominantly serve minorities. Whites go to one set of hospitals, minorities go to another set of hospitals. There are minority-serving physicians. And remember, I told you that they're already overburdened because of the way Medicaid reimburses. And now you're going to take 17 million people and put them into those primary care settings. Real problem, just real fundamental problem. And if you go talk to those docs, they're sitting there saying, do I want to deal with that expanded Medicaid population? I'm already burdened. So there's a real important conversation that nobody's having about what's going to happen in those zip codes. So here's how it looks. So this is the uninsured population by state. Basically, healthcare reform was done for California and Texas. I mean, they have an extraordinary number of uninsured people in those states. I think the number is somewhere around, don't exactly quote me, I think about 25% of all the uninsured people in the country are in California and Texas. And so they're going to be coming into the marketplace. And we've mapped it out. So we can look at what percent are coming into the expanded Medicaid, what percent are coming into the exchanges down to the zip code. And they're not just coming in. These are consumers who have not had continuous health care. So they're coming in with a whole host of problems. And if you talk to the insurers, they don't know what to expect. How expensive are these populations going to be? What do they cost? And you're going to add on to that mix of the jail population. Well, in preparation for this meeting, did a lot of conversations with folks in the healthcare industry that we knew and began to talk to them about the jail population. They're afraid. They don't know what to anticipate. There's no great rush to that market in order to provide care. And you've got a mixed environment you're talking about because they're going to get coverage in the jail, and then you're talking about coverage back into the community and how do you make that transition, and they've got a lot of mental health disorders. So there's a lot of bubbling and interest down there about what this population needs and how we're going to be able to manage them. I think this is an extraordinary opportunity. I want to be clear that I think healthcare reform is something that the conscience of America should have done a long time ago. I mean, I live here in Washington, and I hear the conversation all the time. As my mother would say, I don't know how you fix your mouth to say that somebody should not have health care. I don't know how you shape your mouth to get those words out, because implicit in that is that you are going to put that person's life at risk. Fundamentally, you're going to put that person's life at risk. And so now we sort of got that discussion maybe behind us, but the real critical issue now is, so what is the quality of care that we're going to provide them? How are we going to structure this so that we make sure that those physicians, there are about 40,000 of them down there in the primary in primary care in the minority community, are operating at the top of their license. How do we do that? How do we fix that? And I think I want to sort of make a point here before I end, because I think it's important, because I think we all get confused about healthcare. The way we think about healthcare is that we think that the denial of health care to someone else is really that person's loss, that it really ain't about me because I've got covered. See, and so we're really negotiating about my neighbor, and maybe not my neighbor's, my immediate neighbor, is that person on the other side of the track that I'm really talking about. But let's understand something very, very important about healthcare. Because we have to acquire healthcare collectively, we have to pool all of our money, right? Be it Ted Kennedy or the guy in the jail. Every resource gets pooled together because those dollars are used to innovate with, to build technology, to distribute that technology. You cannot build a quality healthcare system for the 1%. Ain't possible. Ain't going to happen. They can't afford it. Not going to happen. The fact that you have expanded healthcare means that you've expanded the consumer base. By expanding the consumer base, if you don't stifle the baby, you spur innovation. You create interest in the marketplace to bring new technologies on. And those new technologies will help the 1% and they'll help those who are in jail. And that's a profound and important thing to constantly bear in mind. Because in this conversation, we always think that we're talking about that lazy guy back there in the corner who don't want to work. And you're asking me to take my money and give it to him who went to jail, right? That's what you're saying. But what you don't appreciate is that that system, structurally, we allowed people with mental health disorders, because they didn't have an insurance card, we allowed them, right, to self-medicate, to abuse their family. And then we incarcerate them as a form of therapy. That was our plan. That's the system. That's what we produced. That's the model. And so what we're trying to do is break those patterns. And in order to break those patterns, it's not just giving them the card. We need to make sure that what they acquire with that card gives them quality health care, breaks the pattern. That's what health disparity elimination is about. It's breaking historic patterns that we've built. And so one of the things, I just want to conclude, one of the things that we're working on that's part of this break the pattern is something that I really take a lot of pleasure in talking about. It's called the National Clinical Trial Network. One of the things I think a lot about is that as America changes and we get this demographic shift in the country, and we bring in new voices and people who have a different set of needs, we need the political philosophy will get informed by that. And as we look into the 21st century, what we really want to do is have a healthcare system that is self-aware, that appreciates the diversity of the population that it has to serve, that is anticipating, not waiting until they get sick, but anticipating their needs, preventing aggressively, and investing. And we can do that. And part of what we're doing here in this National Clinical Trial Network is building that infrastructure, that 21st century infrastructure that takes big data and information and uses it to anticipate where we got to go. And I think this jail population is really important because how we treat the least of us is exactly what our healthcare system ought to be judged by. That's exactly what we should use as the benchmark. And if we're doing that, if we can show by the numbers that we're doing that, then we've got a 21st century healthcare system. Thank you.